I'm Dr. George Delgado, the president of Steno Institute, dedicated to research, education, and increasing the awareness around abortion pill reversal. We're giving women a second chance at choice. I'm also the president of Delgado Medical Consulting, helping small and medium-sized businesses stay open during the pandemic. And I'm the medical director of Culture of Life Family Services in San Diego County. I'm going to share my screen as I ask the question, do women really have a second chance at choice? Are they really able to reverse their medical abortions? It may not be too late to save a life. So my main points today are going to be that mifepristone reversal is safe, reversal is effective, and women given the opportunity to reverse the effects of mifepristone are very grateful. Mifepristone goes by many names. You may be aware of them, including RU46 and Mifeprex. There is some confusion even among physicians about the difference between the abortion pill and the morning after pill. Where the morning after pill is often called emergency contraception, it's designed to be taken within 72 hours of intercourse, except for Ella or Ulipristol. And the intent is to prevent pregnancy. The woman does not know she's pregnant, but we do know, and this is a topic for a whole other talk, is that often it appears that these morning after pills are contraceptive. But the woman does take it with a contraceptive intent, not knowing if she's pregnant. On the other hand, mifepristone is approved for use up to 10 weeks of pregnancy in the United States. It's a deliberate attempt to abort a known pregnancy. That's why it's called the abortion pill. Some important bottom lines: mifepristone and other medical abortions are equivalent to traditional surgical abortions. Two end results. Number one, the embryo or fetus ends up dead. And number two, the woman is victimized by the abortion medical complex. The key difference, however, is that medical abortion is now reversible. There's a window of opportunity. And I want to talk about the battle at the progesterone receptor. Imagine the progesterone being the key that fits into the lock being the receptor, and the progesterone, the proper key, turns that lock so that the door opens. The door opening is a hormone effect, the good things that progesterone does in the body. However, we've all had the experience of putting a key into a lock that fit into the lock, but didn't turn the lock. That's a false key. That's analogous to a receptor blocker. That's what the mifepristone does. It occupies the receptor, but does not activate the receptor, so you do not get the hormone effect. Now, if we put more of the good guy keys, more progesterone in front of that lock, when the mifepristone key comes out, then the progesterone is ready to go in. That's the whole idea behind progesterone supplementation, to outcompete the mifepristone at the receptor site. So what are some of the actions of progesterone? Why is it called progesterone, progestational? Because it prepares the lining of the uterus for the implantation of the embryo. It promotes development of the maternal part of the placenta called the decidua basalis. It inhibits uterine contractions, and it keeps the cervix closed like a biologic valve. It also promotes growth of milk-producing cells in the breast, but inhibits milk production. So the mifepristone, by blocking the progesterone, disrupts the lining of the uterus, causing separation of the maternal part of the placenta, the decidua basalis, from the embryonic part of the placenta called the chorion. Most of the placenta comes from the chorion, so essentially the placenta is detaching from the wall of the uterus. This cuts off the supply line of nutrition and hydration from the mother. The preborn baby loses nutrition and hydration and therefore dies. The blocking the progesterone also leads to uterine contractions, and you get a disinhibition of prostaglandin production. More prostaglandins cause more contractions, more dilatation of the cervix. The cervix softens and ripens and opens. Now, how about mifepristone abortion in the United States? It's been approved since the year 2000. Currently, 30 to 45% of all abortions are performed with mifepristone. That is about 300,000 to 450,000 mifepristone abortions a year in the United States. The FDA-approved protocol is to give mifepristone up to 70 days after the last menstrual period, or first day of the last menstrual period, that is 10 weeks of pregnancy. On day one, mifepristone 200 milligrams orally is given. 24 to 48 hours later, misoprostol or Cytotec, 800 micrograms is taken buccally between the cheek and gums because that causes fewer side effects. That second drug is taken at home, so the woman has her abortion forlorn in her bathroom by herself with the remains of the baby going into the toilet. Why two drugs? Well, mifepristone is very effective at killing the embryo or the fetus. Survival is up to 25%, but up to 40% of the time, there will not be complete emptying of the uterus. That's why the misoprostol is given, because it's very effective at causing uterine contractions. That gives us a window of opportunity between the two drugs. Progesterone can reverse the effects of mifepristone, but we do not currently have an antidote for misoprostol, the second drug. This was our first study published in 2012, describing cases of using progesterone to reverse mifepristone. Since that time, we've had documentation of over 2,000 babies being born after successful reversals. As far as a control group, our studies to date have been observational case series. Historical control groups are available in literature. And as you'll see going forward, placebo control groups will not be ethically appropriate because these women want to save their babies. We published a landmark study in Issues in Law and Medicine, Embryo Survival After Mifepristone, a systemic review of the literature. Dr. Mary Davenport was the lead author. And this is how we came to our historic control rate of 25% survival if a baby is exposed to mifepristone and nothing else is done. In 2018, we published a case series detailing the successful reversal of the effects of mifepristone using progesterone, over 250 successful reversals. With our high-dose oral protocol, the reversal rates were 68%. With the injection protocol, 64%. We're very, very pleased with that. So the survival comparison with no treatment, 25% of the embryos or fetuses survive. With the best treatments, 64 to 68% survive. How about birth defects and preterm delivery? Well, in our large study, the birth defect rate was no greater than the general population. The preterm delivery rate was actually lower than the general population. American College of Obstetricians and Gynecologists has stated in their practice bulletin in 2014, which was reiterated in 2020, that there's no evidence that mifepristone is teratogenic, that is, does not cause birth defects. Progesterone has been deemed safe by the FDA back in 1999. We've had opposition from medical groups and mainline journals. Well-known medical abortion researcher and abortionist Mitchell Crennan designed a study that he said would disprove APR. He canceled the study ostensibly for safety concerns. It was published in the Green Journal, Obstetrics and Gynecology, in January of 2020. It was a randomized controlled trial, double-blind, placebo-controlled, 2 arms, a placebo group and a high-dose progesterone group. When you look at the intention to treat analysis, that is, all the patients who started the study, out of the progesterone group, 4 out of 6 patients had continued pregnancies at 2 weeks for a 67% success rate, while in the placebo group, 2 out of 6 continued pregnancies at 2 weeks, 33% survival. Very similar to our numbers. If you exclude the 2 patients who exited the study prematurely, progesterone, 4 out of 5 continued pregnancies, that's 80% survival. Placebo, 2 out of 5, 40% for survival. His conclusions, well, the first, patients who receive high-dose oral progesterone treatments do not experience side effects that are noticeably different from placebo. That's wonderful for us. Other conclusions, 2 patients required suction aspiration. Both were in the placebo group. They required suction aspiration. 1 patient required transfusion who was in the placebo group. Therefore, it was the placebo group, not the progesterone group, that was unsafe. Mifepristone alone for abortion was shown to be unsafe in this study. Attempting reversal was not proven to be unsafe. As far as our pillars of support, we have biologic logic. That is, in all biologic systems where you have 2 molecules competing for a receptor, if you raise the concentration of one, it's going to win the battle at the receptor. That's what progesterone does. Animal model, there's a rat model showing that progesterone reverses the effects of mifepristone, and our data. So the conclusions are that mifepristone reversal using progesterone is safe and effective. We have 64 to 68% reversal rates with our best protocols. We have a high-dose oral protocol, IM injection protocol, and possibly a high-dose vaginal protocol. When women want help, they go to the internet and they find abortionpillrescue.com. Here's the website. Here they can talk to an experienced nurse who can put them in the right direction. There's an Australian mifepristone reversal network that we helped spawn in Australia. There's a Russia APR network started by Dr. Alexei Fokin. In Switzerland, they're starting a European APR network. And in Ireland, they're starting another one and starting a study too. The Steno Institute is responsible for the medical protocols of APR as well as advancing research and providing an unbiased platform for pro-life research because there's so much bias out there, unfortunately. Steno Institute is named after Nicholas Steno, who was a 17th century Danish anatomist, physicist, geologist, and paleontologist who first described the parotid duct, which is called the duct of Steno, often called Stenson's duct in English. He's considered the father of modern geology. Later, he pursued philosophy and theology, became a bishop. He was a very pious, humble bishop. Our board of directors include Dr. Matthew Harrison and Dr. Mary Davenport. Our board of advisors include the Most Reverend Salvatore Cordileone, the Archbishop of San Francisco, Philip and Tiffany Rivers, Charles Lamandry of the Thomas More Law Society, as well as Father Frank Pavone. We are planning and hope to launch a randomized control trial comparing two different progesterone treatments. Will not have a placebo group. And we have planned animal studies in collaboration with Dr. Stephen Samut at the Department of Psychology at Franciscan University. He's already developed a rat model for abortion, medical abortion. So remember, if you're interested in finding out more about this, stenoinstitute.org. Thanks very much. And I want to remind you of the Steno Institute Life Affirming Research and abortionrescue.com. Thank you very much for listening and have a great day. Thanks.